Triple row modification of the knotless speed bridge technique. The authors have no disclosures relevant to this topic. Rotator cuff pathology is the leading cause of shoulder-related disability in the United States, with approximately 250,000 rotator cuff procedures performed annually. Arthroscopic rotator cuff repair has become the predominant surgical approach. Double row constructs such as the suture bridge technique have been developed to improve repair anatomy and fixation strength. However, repair rates from 11 to 40% remain, especially when treating larger tears. The triple row modification of the suture bridge technique has been shown to improve repair anatomy, provide an additional point of fixation, increase rotator cuff footprint contact area and pressure, and reduce the repair rate. The triple row modification of the speed bridge technique, a knotless configuration, provides similar benefit. Case presentation: the patient is a 55-year-old male landscaper with 6 months of shoulder pain. He reports increased pain and loss of ability to perform his job. Pertinent physical exam findings include full passive range of motion, 4 out of 5 weakness with supraspinatus testing, and a positive Neers and Hawkins test. MRI demonstrated a large full thickness tear of the supraspinatus tendon. Surgical indications include full thickness rotator cuff tears or high grade partial thickness tears treated with completion of the tear and failure of non-operative treatment. Contraindications include irreparable rotator cuff tears, significant glenohumeral arthropathy, or medical comorbidities that make the risk of anesthesia too high. The preoperative evaluation includes a complete and thorough physical exam, including shoulder range of motion and rotator cuff strength. Imaging routinely includes x-rays, AP, Grashy, supraspinatus outlet, and axillary views are obtained. Ultrasound is a quick and easy way to evaluate the rotator cuff. It has similar accuracy in evaluating for full thickness rotator cuff tears and muscle atrophy. An MRI is really the gold standard for evaluating the rotator cuff. It has high sensitivity and specificity for detecting tears. In terms of surgical technique, it starts with patient positioning. The patient is placed in the lateral decubitus position and stabilized with a beanbag. The upper extremity is placed in balanced suspension at approximately 60 degrees of abduction and slight forward flexion, with approximately 10 to 15 pounds of weighted traction. Here we have the patient in the lateral decubitus position with the typical portals, a posterior portal, an anterior portal, an accessory lateral portal off the lateral border of the acromion, and a lateral portal. Here we've got a large tear involving the supraspinatus and portion of the infraspinatus. We're debriding some of the degenerative portions of the tear. We'll prepare the tuberosity to bleeding bone to stimulate a healing response. I always like to look at the cuff from 2 different angles. It allows me to do a little bit more preparation. It also gives me a better idea of the anatomy of the tear. Once we have the tear and tuberosity prepared, we're going to place cannulas. The scope is back posteriorly. We're going to place an anterior cannula. We'll place an accessory lateral cannula right off the lateral border of the acromion. We place our medial row anchors through this cannula, and then a lateral cannula. So we've got 3 cannulas, and we're viewing from posteriorly. When placing anchors, I like to view from the lateral portal. It allows me to get a better idea of the spacing anterior to posterior when I'm placing multiple anchors, and also make sure I get right on the articular margin. So we're placing our anterior anchor here. We've got the arm adducted to give us the appropriate trajectory. Before final seating of the anchor, I always like to screw back this sheath so that I can make sure that that anchor is buried just under the bone. I want rotator cuff to bone contact and not rotator cuff to tendon contact. We're going to shuttle these sutures out our anterior cannula, and we're going to place our second anchor more posteriorly. Again, we've got the arm adducted to get the appropriate trajectory. Once we have our 2 anchors placed, I'm going to place the scope back posteriorly, and we're going to pass the tapes through the rotator cuff. We do this through the lateral portal. I'm going to reach in and grab this tissue, and I'm going to pull it towards my anchor to make sure that I'm passing this suture anatomically. Once it's passed, we're going to shuttle it out of the anterior cannula to get it out of the way. And then we'll pass our more posterior tape through the cuff in similar fashion. Once I've got the tape passed here, we're going to again pull it out through our anterior cannula. Once I have both tapes passed, we're going to place a suture into the leading edge of the cuff. This is going to be for the middle row anchor. We're going to grab a bite of cuff here at the leading edge. I like to mark this suture with a marking pen at its midpoint so that when I pull it through the cuff here, once I get to the marked area, I know I'm going to end up with 2 equal limbs. I'm going to take a second bite about 5 millimeters posterior to my first bite. If you space out these bites too much, you bunch up the cuff. So now I'm going to pull on this suture and reduce the cuff anatomically. Sometimes you need to pull it anteriorly, sometimes posteriorly, depending on which way the cuff retracted. But typically you know you're right when you eliminate the dog ear. Once I know where I want to put the cuff, I'm going to mark the spot on the tuberosity with a radio frequency wand, and then mark our lateral row spots as well. This one is just posterior to your bicipital groove. This one is just anterior to these vessels, which are commonly present. So now we're going to punch for the middle row anchor, load our tapes. There is a little bit of a learning curve to this. These tapes are thick and they don't glide through the eyelet of the anchor very well, so you have to put the appropriate amount of slack in the construct before you put it down, so that you don't over reduce it or under reduce it. So there's a little learning curve on how much slack to put in here so that when you deploy the anchor, the cuff is reduced anatomically. So now I've got, again, the cuff tacked down anatomically. We're doing this before final fixation and compression. There's no dog ear. I'm going to grab 1 limb of tape from each of the anchors, pull out any slack in the system, load them into our anchors. I'm going to pull out the slack again, and then I'm going to add a little bit. Again, these tapes don't slide through this eyelet very well, so if it's too tight, it'll cut out through the bone and you'll compromise your fixation. Now we're going to grab the 2 remaining tapes for our posterior lateral row anchor. Pull out the slack, make sure there's no slack in the system, but then add a little bit so that as we deploy the anchor, it doesn't cut out of the bone. So this is the triple row modification of the speed bridge technique. Again, the middle row suture and anchor reduces the cuff anatomically before final fixation and compression. It eliminates dog ears. It spreads the cuff over the tuberosity anatomically and provides an extra point of fixation. Technical pearls, medial anchors are placed through the accessory lateral portal while viewing from the lateral portal. Sutures are passed through the rotator cuff while viewing from the posterior portal, working from anterior to posterior. Appropriate slack should be placed in the tape for the middle row anchor to ensure anatomic reduction of the rotator cuff to the footprint. The anterior lateral row anchor is placed just posterior to the bicipital groove. The posterior lateral row anchor is placed just anterior to the vessel branches, running longitudinally up the posterior proximal humerus and posterior rotator cuff. Potential complications: intraoperative use of the lateral decubitus position lessens the risk of hypotension and cerebrovascular events when compared to the beach chair position. Neuropraxias can be avoided with proper patient positioning. Proper portal placement is critical to avoid injury to neurovascular structures around the shoulder. Postoperative complications: infection is rare after arthroscopic rotator cuff repair but leads to worse outcomes. Thromboembolic events are also very rare. In terms of postoperative management, patients are placed into a shoulder sling with an induction pillow for 6 weeks. Postoperative pain is controlled with interscalene block and indwelling catheter that remains for 2 to 3 days. Physical therapy is generally started within a week, allowing for early gentle passive range of motion. Patients are generally seen at 2 weeks to evaluate wound healing and remove sutures. Follow-up is performed at 6 weeks, 3 months, and 6 months. Our postoperative physical therapy protocol starts off with the maximum protection phase from days 1 to 14. Treatments include gentle pain-free passive range of motion, submaximal non-painful isometrics, and rhythmic stabilization drills. The moderate protection phase is from weeks 3 to 6. Treatment includes initiating manually resisted external and internal rotation, as well as resistance tubing and neutral arm position. The intermediate strengthening phase is from weeks 6 to 12.
Treatment includes increased resistance on strengthening exercises, as well as initiating progressive closed kinetic chain exercises. The advanced strengthening phase is from weeks 13 to 24. Treatment includes continuing to progress advanced strengthening exercises and upper extremity advanced plyometric exercise programs for overhead and contact athletes. The final phase is discharge testing and planning from months 6 to 9. Biomechanical assessments of performance are made to approve initiation of interval return to sports programs.
Return guidelines. At 6 months, we start them on advanced upper extremity plyometric strengthening program. Throwers can begin their interval throwing program, and golfers can begin an interval return to play program. At months 9 to 12, decisions are made whether to endorse full return to sport or previous activity levels. Despite advances in rotator cuff repair techniques, standard double row re-tear rates remain as high as 40%, especially in larger tears. The triple row modification has demonstrated significantly lower re-tear rates. Bucket et al. In the Journal of Shoulder and Elbow Surgery looked at a series of 101 shoulders with retracted full thickness rotator cuff tears that were treated with triple row repairs. Once the re-tear rate was 4.9%. Tanaka et al. In arthroscopy compared 212 double row repairs using the suture bridge technique to 206 triple row repairs. Re-tear rates were significantly lower in the triple row group, 3.4% compared to the double row group, 9.4%. In conclusion, although the vast majority of outcomes following rotator cuff repair are good or excellent, and re-tear rate of upwards of 40% in larger tears repaired with standard double row technique leaves room for improvement. The triple row modification offers improved biomechanics with increased footprint, contract area, and pressure when compared to the double row repair. These improved biomechanics, accompanied with a more anatomic repair, should lead to improved healing rates.